Being a doctor has always been considered a noble and prestigious profession with a good paycheck. But the American Medical Association issued a warning that about 1 in 5 U.S. physicians are leaving or scaling back patient care, according to data released more than 2 years ago. Dr. MaryAnn Wilbur, who lives in Southwest Florida, is one of those doctors who walked away from patient care. In her new book, The Doctor's No Longer In: Conversations with U.S. Physicians, she shares the reason why doctors are walking away. Dr. MaryAnn Wilbur joins us now. Welcome, doctor.
Thank you.
So it is hard to imagine someone who would spend years building this career, over $200,000 also building this career, and what a lot of us see as a prestigious, profession. Mm-hmm. Why did you decide to put down the scalpel?
Yeah, this is not the kind of decision that physicians take lightly. I spent 5 years in undergrad, and then 5 years getting an MD and PH, and then I spent another 8 years doing extremely long hours in training at Hopkins, and then I was only an attending GYN oncologist for 4 years. I'm invested in terms of money, time, emotions, you name it. But for me, I got to a point where it's not, I miss my patients and I miss being a doctor every single day. Mm-hmm. But it got to a point where I couldn't practice good medicine in the current context of US healthcare because of all of the constraints, most of them being money and time, which actually comes down to money. And so we've got such a problem in our system that the physicians are feeling pressured away from doing what they knew to be right for the patient. And for me, it got to a point where it was just absolutely untenable.
I heard you talk about this sense of feeling morally compromised, mm-hmm. a lack of autonomy. What did that look like for you and the physicians? Because you've now interviewed a bunch of physicians who are just like you. What does that look like? It
looks different for everybody, right? Because every physician is a human. And so what specialty and where you practice and what demographic you are, it's going to affect things. But for me, I'm a mom and I was a GYN oncologist. And so that meant that my patients would be referred to me. The most common story was a woman is having some kind of irregular bleeding, a primary care or a GYN does an endometrial biopsy, identifies cancer, refers the patient to me. So I meet them and I say, I'm very sorry to hear about your cancer diagnosis. It's almost always endometrial cancer if it's the cancer of the uterus. And so we usually are discussing hysterectomy. But it had gotten to the point where even a standard of care, when the patient and I came to, okay, so we're going to plan a hysterectomy, and I would do what you would expect the standard of care according to the textbooks would be. But the insurance companies are saying, why do you want to do that? You really want to do that? Do you want to do it differently? And I'm like, no, I don't. I don't want to do it differently. I want to do the standard of care. And it got to the point where I really felt like I was either going to be able to look myself in the mirror or keep operating. And so I walked away.
We often hear doctors saying about how limited, especially general practitioners, right? Family physicians, mm-hmm. How they feel pressured, right, to get in those patients, I guess, within 20 minutes?
Oh, if they're lucky. 20 minutes is a dream.
Wow.
No. 20-minute slots, but those are usually double or triple booked. And then you have to document, and then you have to do the MyChart messages, and then you have to do the billing, and then you have to do all of the other things that are, in the notes. And the nurse came and asked you a question, and, so 3 minutes.
You say the big issue is that the dollar is mm-hmm. at the center of the system and not the patient.
Yeah. So different countries handle healthcare differently, right? In the US, the way that we created our healthcare system was actually backwards, and it's just a mistake of history. So right around the time of World War II, a lot of medical technologies came to be, antibiotics, good anesthetics, quality imaging, a lot of things. And all of a sudden, access to those things became important to the American public. And what was happening during World War II was a lot of the men were off at war, women worked in the factories, and they were getting pulled from factory to factory. So the federal government said, there's a cap on salaries. You can't pull, one woman from another. So you can't challenge her salary. So what would you offer to bait her to come to your factory, but not challenge her salary? Well, we know what she's worried about. She's a mom, right? She wants to make sure that her kids have access to those antibiotics if they need them and things like that. So they offered health insurance. And that's how it came to be. The first people to do it was Blue Cross Blue Shield. And it was really interesting. I mean, I think it came from a, not a bad place. They were like, we'll set this up. But nobody had any real thought about how you would do this. So they set it up the way that you would set up any other insurance. So I usually liken it to flood insurance, right? And so a lot of us around here have flood insurance. And then the families who do suffer a flood, they, in theory, get what they need to fix their house. But that's all based on a gamble that not everybody's house is going to flood, right? Yeah. So now if you bring that back to health insurance, what are the chances that every human body is going to break down? 100%. Yeah. The human body is mortal. So this whole system was built with a fatal flaw put in. But then to make it even worse, what we did was we said, okay, how are we going to pay for these services? You know what we're going to do? We're going to put in a fee-for-service system, which is how you pay a mechanic, right? So they do something, they charge you. They do something else, they charge you. And between these two errors, we now have a system that is based around doctors doing things and either maybe trying to do things more than they should, or at the very least, the perception that your doctor is going to want to do more, right? So the insurance company is accusing me of wanting to do a hysterectomy unnecessarily. Am I? Probably not, but maybe. But this insurance company definitely is going to think that I'm doing it. So they put all of this staff into fighting me, and then my office has to put more staff into fighting them. And this is now created a situation where between me and the patient, who just had cancer and needs her uterus out, 17 people are now between me and the patient. 17 salaries. That is why our healthcare system is so bloated and so inefficient.
Dr. Wilbur, thank you for your time with us, and thank you for sharing your story and telling the story of so many other physicians.
You're welcome.
Thank you.